Good evening and welcome to this, the grand finale of the 36th season of Doctors on Call. Tonight we're answering your questions about the diagnosis and treatment of heart disease and high blood pressure. I'm your host, Dr. Ray Christensen from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School here in Duluth. I'm pleased to welcome our panelists tonight, Dr. Disha Mookherjee, a cardiologist with St. Luke's Cardiology Associates, Dr. Kalkidan Bishu, a cardiologist with Essentia Health, and Dr. Emily Onello, a family physician and faculty member at the medical school. Call in with your questions locally at 218-788-2844 or toll free at 1-877-307-8762. Our medical students answering the phones tonight are Jacob Bentley of Austin, Minnesota, Hannah Fordahl of Zimmerman, Minnesota, and Blake Holbrook from Cold Springs, Minnesota. I want to take a moment and publicly thank Linda Liskowitz for the work that she has done in making this program possible. I know that I'll run out of time at the end, but Linda is the one that makes this program happen week after week after week and provides our expert panels and makes sure that we have the information we need to make this happen. She, with Julie Kellner and the other people here at the station, make this show work. So tonight we'd like to go around and just let our panelists introduce themselves. Emily, do you want to start?
Sure. Thank you, Dr. Christensen. I'm Emily Onello, and I'm a family physician, and I really enjoy working with Dr. Christensen and the other faculty and students at the University of Minnesota Medical School and here on the Duluth campus.
Dr. Bishu.
Yep. I am Kalkidan Bishu. I'm a cardiologist with Essentia Health based in Duluth. It's my second time on the show with Dr. Christensen. I'm happy to be here.
Welcome.
I'm Disha Mookherjee from St. Luke's Cardiology Associates. I am the Director of Cardiac Rehabilitation there, as well as Director of Echocardiography, and I'm thrilled to be here.
Thank you all for coming. We really do appreciate it. I think the best place to start probably is with hypertension tonight. So Emily, as a family physician, you and I see an awful lot of hypertension. Do you want to tell us a little bit about what hypertension is and what are our current guidelines for us older people?
Sure. I really enjoy talking about hypertension or high blood pressure because I think conceptually it's something a lot of us can relate to. If we've ever inflated a tire on a car or a bicycle, we get that idea of what pressure means. And so hypertension is sort of the fancy scientific word for elevated pressures within our blood vessels. And specifically, we're talking about our arteries when we talk about high blood pressure generally. So it's the amount of pressure that the blood sort of exerts on the wall or the wall exerts on the blood as it travels through. And as many of you probably know in the viewing audience, your blood pressure can change throughout the day. Various things can affect it. So we talk about numbers as if they're these fixed points that we need to achieve, but blood pressure varies normally with physiology, with sleep or emotional upset or caffeine ingestion. But what you generally want is numbers that vacillate within a range below a certain value. And I think for adults, we were speaking before the show, there's general agreement that the guidelines have just nudged a little lower. So the expectation is that blood pressures in healthy adults will be sitting with top numbers less than 120 and bottom numbers less than 80. We used to be not so worried if your top number was between 120 and 130, but now we are paying more attention because we know the long-term harm that can affect on the blood vessel walls. So I think, I'll start with that.
Yeah, absolutely. And it's not only, it's a beautiful explanation, but it's not only just the effects of elevated blood pressure on the blood vessel wall, but then it can lead to higher incidence of stroke and heart disease and kidney disease and eye disease, and so it can really affect our entire body. So it's really important.
Yeah, I completely agree with what my co-panelists said here. With hypertension, it's the thing to realize about it is that it's one of the top 2 causes of cardiovascular morbidity, death, stroke, heart attacks in the United States. And so, which is why it should be a big focus for all of us, family care providers, cardiovascular providers, and recognizing it early, which is why we talk about, you know, blood pressure of 120 to 130 being a time to start acting. You know, it doesn't necessarily mean everybody has to take medications to reduce their blood pressure, but it's recognizing early on the impact of elevated blood pressure for a prolonged time can have on quality of life and hard, you know, outcomes, and instilling programs, diet, exercise, weight reduction, you know, modification of other risk factors early on.
Quitting smoking.
Quitting smoking, exactly. So it's a big public health problem, should be a priority, and we should all act in unison, healthcare providers, patients, communities, in recognizing it early and treating it, you know, using all the tools in our box.
Definitely.
So we've stimulated calls really quick. Automatic blood pressure monitoring, wrist accuracy.
Oh.
Did you say wrist?
The wrist?
Wrist, yep.
I feel strongly about it, but.
So,
Okay.
you know, I think some, you know, I'll tell you what I think.
Okay.
Some type of blood pressure monitoring is better than no monitoring. And as long as, so, you know, guideline-wise, medical practice-wise, we have 3 ways that have been validated in measuring blood pressure, monitoring blood pressure. One is in the clinic. The other one is home blood pressure monitoring using automated blood pressure, you know, monitoring machines. And the third one is we have ambulatory blood pressure monitoring machines. Now, if you have a wrist, you know, what I tell my patients is if you have a wrist monitor and if it correlates, if you bring that wrist monitor, it correlates with the blood pressure I get in the clinic, I would rather you do that to monitor your blood pressure than not to know what's going on. So really, I think it's just recognizing a problem and monitoring it either in the clinic visit or as an outpatient, and instilling interventions.
Yeah, I agree. The key that you said that I totally agree with is that it should correlate with the blood pressures in the office. So I actually usually tell my patients try not to get the wrist cuff and really go for the upper arm cuff because that tends to be more accurate. And it, you know, being an electronic cuff is just perfect.
Why do cardiologists tell people with hypertension to take their blood pressure 3 times a day and to take the lowest as their true blood pressure?
I think so I'm going to have to disagree with that. Comment in general. Actually, we would like to know that. So the recommendations, the guideline recommendations, is to actually pick the highest blood pressure. You know, the first time when you're doing your blood pressure, checking your blood pressure at home, check it in both arms, pick the highest blood pressure, and that is the measurement we should take. You know, again, to make a diagnosis or monitor blood pressure measurements. However, there's different techniques. You know, if you just had a cup of coffee and sat down to have your blood pressure measured, and that is wrong. You know, I would not, if you applied appropriate technique, then we should be taking the higher blood pressure measured on the same date from the, you know, multiple, from the 2 arms. You know.
Yeah, so I mean, I'll usually, that recommendation for 3 times a day can vary depending on what your situation is. And so the doctor may recommend that. Typically on average, I'll tell people to take it first thing in the morning before their coffee, both feet on the floor with their arm at heart level, and they should wait 5 minutes, just take some deep breaths, check it then, and then do it again before bedtime. And do it then as a minimum. And really what matters the most is what the trend is, not necessarily what the individual numbers are.
Emily, does eating salt affect your heart disease and hypertension?
Oh, I really love that question. That's a great question. I think in a word, yes. I think it's a complex interaction, and there may be some underlying tendencies. Certain ethnic groups or genetic genetic backgrounds may be more susceptible to salt raising blood pressure or impacting blood pressure. But I think the idea that salt, and when we say salt, we're really talking about sodium or sodium chloride, table salt, does tend to have that cause the body to sort of retain fluid, is what people will say, and that extra fluid adds more pressure on the blood vessels. So yeah, low sodium diet is part, as you mentioned earlier, one of the approaches to controlling blood pressure and also just general good health. And most American diets contain I think, nearly double the recommended amount of sodium. So most of us who are watching this program and on this program probably could reduce the salt intake that we have.
So uncontrolled blood pressure ramifications of too high or too low. So what's too high and what's too low? Do we have numbers that we can work from on that? Any one of you can jump in.
Oh, I get more concerned about too high. Usually for the too low part, I don't worry about a too low of a blood pressure as long as the patient feels well. Of course, if you have a fever and you're not feeling well and your blood pressure is very low, that's a reason to go to the hospital. So I wouldn't say that there's anything that's too low as long as the patient feels okay. Too high, again, we were just talking about the guidelines, and so now really anything over 120/80 is considered elevated. So it's a discussion to be had with your doctor.
Well, you know, this gentleman calls in, he's 75 or 80, and so I'm getting there too. So what is the standard number for us older people? Is it really that low?
So, so the guidelines, so cohort studies, observational studies, and clinical trials have looked at outcomes. Hardcore, you know, when we talk about outcomes is, you know, who has a heart attack, who gets a stroke, and, you know, cardiovascular death, exactly. So a lot of times the numbers, the lower the blood pressure is, the less the bad outcomes we get, you know. So there is a direct inverse relationship of blood pressure with incidence of stroke, death, and heart attacks. Now, however, when it gets too low, you know, there's a sweet spot. The sweet spot is 120 to 124 systolic blood pressure. Close to 120 for the systolic blood pressure is when most people do well. So if we can get to that level, it's what we would consider ideal, you know. Now, the current guidelines recommend that they would call, and this is, would say that blood pressure less than 120 is normal systolic, 120 to 130 is elevated, and then anything above 130 is considered hypertension. So there are two stages, 140 is stage 2, 130 is stage 1. But again, the critical thing here is to realize, you know, it's not, the treatment of hypertension, it does not necessarily mean your blood pressure is 125 and you carry a diagnosis of elevated blood pressure does not necessarily mean you need to be on medications right away. It means it's time to start acting. And the first act is non-medication, lifestyle changes, and then if we're not making progress with that, we move on to medical therapy.
So that's kind of an important piece, and Disha, that's kind of your, Emily too, lifestyle changes. What kind of things should we be doing? Emily, maybe you want to jump in on that.
Well, I'm going to reiterate what Dr. Mookherjee said, which was quitting smoking. I mean, I think people focus a lot on supplements, which often can be very expensive.
Q10. Somebody asked about Q10.
Okay, exactly. And
licorice.
You know, we start with the, you know, I think cigarette smoking, tobacco use, and nicotine in its other forms. I know that there's been some interest too in even some of these newer forms of e-cigarettes and things, and generally I'm advising against that as well. Obviously moderation in alcohol intake, and then some of the other things that have been mentioned as well. Lots of good benefits from healthier diets, weight loss, exercise, things like that.
Just even just doing 30 minutes of cardio exercise every day or 150 minutes a week can do wonders for your blood pressure, and it can even work as well as one blood pressure medication. So I encourage all my patients who can exercise to exercise. And I want to reiterate the alcohol part of that. I have several patients who really like their beer and their wine, and I appreciate that. However, sometimes moderation is the key, and really for men, I would just say, when people ask me for more specific guidelines, I do say that for men, not more than 2 beers a day, and for women, 1 or 1 4-ounce glass of wine a day at maximum, and that's if you have no heart disease or no other heart issues. The recommendations can be stricter for people who have heart disease.
Yeah.
Okay, right and left bundle branch block and leaking right ventricle.
Right.
What does this mean and what can be done about it? You're the valve guy.
Yep. So, well, thank you for that question. Right and left bundle branch block is conduction system abnormality in the heart. Right leaking valve on the right side. So the heart has four major valves, and mice is, on the right side there are two valves. So the pulmonary valve is a valve from the pumping chamber on the right side, the right ventricle, to the pulmonary artery, which sends blood to the lungs. And the tricuspid valve is between the right atrium, the receiving chamber, and the pumping chamber is the right ventricle. So I suspect you're, the gentleman or lady who...
And another question is, at what point do you fix it?
Exactly. So there's multiple, a leaky valve on the right side usually causes fluid accumulation on the right-sided congestive heart failure symptoms. So the standard of care, if it's an isolated right valve leakage problem, is actually medical therapy at this point. That is the standard of care. There's this trend where if you catch it early on and it's quite leaky and there's no other comorbidities associated, even if it's an isolated right-sided valve that's leaky, to repair or replace it surgically. Now, it's hard to make a diagnosis and formulate a treatment plan, over the phone, but there's treatments available for a leaky right-sided valve, from medication up to investigational catheter-based therapies, as well as open surgical repair and replacement.
And sometimes when people are undergoing other cardiac surgeries, other valve surgeries or bypass surgery, if they're undergoing heart surgery anyways, and they have a very, very leaky right-sided heart valve, then sometimes they will go ahead and repair it at that time. So
as you talk about coronary arteries, what about SCAD?
I can, it's a very nice, so
that kind of falls to you too.
Exactly, right. So, I don't want to.
And it stands for?
Spontaneous coronary artery dissection, right? And it's a condition where the coronary arteries, without any plaque buildup, spontaneously form a tear, and it can cause a heart attack, essentially. And it's usually common in young, middle-aged women, sometimes seen in higher frequency in pregnancy. And it's so the critical thing about it is being more and more recognized, and the treatment in general is to realize it when it happens and support and be more conservative. So try not to stent lesions, related to spontaneous coronary artery dissection, because it just tends to extend the dissection. So in general, revascularization. So if you have a plaque buildup and you have a heart attack from plaque that's building up, the treatment is to open up the blockage with a stent or with surgical revascularization. In the setting of spontaneous coronary artery dissection, you have to be more cognizant of the fact that stenting can make things worse. So it's really more supportive care and recognizing these issues when they appear in usually people who are otherwise at low risk for coronary artery disease, young women, pregnant women who you would not expect to have a heart attack due to plaque buildup.
There's still a lot that we don't know about it, and so we still are really, I know the American Heart Association is doing a lot of research in that area, because we really do need more research in that area, so to find out why it happens. So.
And associated things. So once you see there's other, so if you have an artery in the coronary that's at risk for a tear, these patients usually have either higher proclivity, a tendency to have disease in other vascular territories. So once you recognize that, we have to start screening for fibromuscular dysplasia, things that might pop up down the line.
Emily, CoQ10, has it been any value?
You came back to that.
I did.
It
was an early question.
Sort of throughout my career, many of these supplements have come in and out of favor. I probably should look to my cardiology colleagues for the latest, but my memory is that there wasn't a lot of bang for the buck. And sometimes various vitamin supplements and things in large trials, I'm thinking of some in Europe, turn out sometimes to be worse. So I don't know. I'll defer to you, but I don't recommend it routinely.
I also don't recommend it routinely. The people that I reserve it for, anecdotally, some patients have said that it's helped them tolerate their statin medicine a little bit better if they've had muscle pain. And so that's the patient group that I'll have them try it if they're complaining of muscle pain with their statin.
Licorice. Is that good or bad?
Well, if it's true licorice, right, and I'm forgetting the compound, it can be linked with elevated blood pressure. I think that's what triggers in my mind about licorice. Back to Dr. Mookherjee's everything in moderation. I think the cases of licorice causing really high blood pressure are people who are super big licorice fans. And I mean, they do sell them in large packets, but I think that essentially a little licorice here and there, I think even if you have a diagnosis of high blood pressure, is okay, as long as you're sticking with a moderate amount.
I'm going to come back to you because it's coming up and we need to talk a little bit about atrial fibrillation. Can you tell us what it is?
Oh my, that's a
Just start us out on what it is.
Yeah,
and then we'll move
kind of
down
an
the line.
intimidating set of words. Atrial fibrillation, I think, you know, unless you study medicine. But essentially, I think I would tell a patient is that the chamber of your heart and how it beats, a chamber is not pumping in a coordinated, synchronized fashion. It's sort of flailing about. And so blood is not moving through the heart as in as nicely choreographed way as it normally would. And so what happens as a result and why we care so much about it is it doesn't pump quite as well, and there's an opportunity for blood to sort of stagnate and then form clots. So we get concerned about it for those reasons, and also sometimes it can indicate that the heart might go into a rhythm that's too rapid. And again, a patient might feel dizzy or short of breath or just generally fatigued. So I guess the take-home point is it's a mild malfunction of the heart relative to other kinds of malfunctions, but its main risks are that blood can form small clots and that the heart can go too fast.
I completely agree with that description. You know, once someone has a diagnosis of atrial fibrillation, we worry about two things. One is rapid heart rate, which can cause symptoms or the heart weakening. The second thing is blood clot forming and causing a stroke. If you have a stroke, the gold standard of care is to keep the blood thin. I'm sorry, if you have atrial fibrillation to prevent a stroke, the gold standard of care is to keep the blood thin. We have warfarin and other novel oral anticoagulation agents. In people who have bleeding problems from warfarin, we have a new technology called, I don't know if you've heard, a Watchman device, where you try to exclude the portion of the heart where clots come from. And essentially, you know, 90% of the stroke in atrial fibrillation comes from a small pouch that we don't know what it does. It's just part of, so like a remnant left atrial appendage. So that's where the clots form. Blood thinners keep clots from forming over there. People who cannot tolerate blood thinners, what we do is we put a door over that left atrial appendage. This is approved by the FDA for the last 3-4 years for patients who cannot tolerate warfarin. We have, you know, we can do that here in Duluth as well. Highly selected group of patients. But the bottom line is, you know, treatment of care, the treatment for atrial fibrillation is prevent the rapid heart rate which causes symptoms and reduce the stroke risk.
Right.
And Dr. Bishu or Dr. Mookherjee, can you go in and ablate that? And did you? I wasn't paying that much attention. Did you bring that up or not?
No, we didn't. Yes, it can be ablated for certain patients, not for everyone. So it's really important, if that's a diagnosis that you're dealing with, that you talk directly with your cardiologist about those kinds of options. I get a lot of questions about why it happens, and atrial fibrillation being an irregular rhythm. And again, going back to the top of the show, hypertension is the leading cause, and obstructive sleep apnea is another big cause of it that sometimes gets unnoticed and overlooked, and so that's been getting diagnosed more and more.
Squeezing time here. Left bundle branch block, right bundle branch block, left anterior fascicular block. Somebody got a quick answer for all of those?
It's not the patient's problem. Let your cardiologist deal with it.
Right. You know, I would not worry.
Cardiology referral.
Exactly.
No. Yeah.
So in general, if it's good for a cardiologist to see the patient at least once. It's not necessarily something to be overly concerned about.
Right.
Is chewing tobacco as bad as smoking cigarettes, Emily?
In a word, I would say yes. I mean, you are still getting, I think, even though it's not an inhaled form, you are still absorbing some drug. I don't know in terms of the amounts. You would have to compare. Some people smoke 1 cigarette a day. Some people smoke 3 packs. So in my mind, yes. I mean, the recommendation is to stop all tobacco products. So.
How does blood pressure affect the kidneys?
So blood pressure affects the kidneys. There's in 2 ways. One is the kidney can cause high blood pressure, and high blood pressure can make kidney kidney function worse. It's a loop. So anybody with kidney dysfunction, the target for blood pressure control is much lower. Anybody with hypertension, we have to watch the kidney function.
Is sea salt better than regular salt?
You know, it's interesting. I hear that a lot from patients. And I'm going to go out on a limb. I have not researched this, but from what I understand is no. I mean, you're still dealing with salt. It may have a prettier package. It may cost more, but it's still salt.
Can blood pressure be different? Can blood pressure be different in each arm?
Yes.
Yes, it can be.
Which one do you go by?
Well, you have to look at the big difference, and if it should be fairly close.
Wow, that's it. We're kind of out of time. I want to thank our panelists, Dr. Disha Mookherjee, Dr. Kalkidan Bishu, and Dr. Emily Onello, and our medical student volunteers, Jacob Bentley, Hannah Fordahl, and Blake Holbrook. All of this season's Doctors on Call programs are available for you to watch again at wdse.org. I'm Dr. Ray Christensen. Thank you for your faithful viewership and great questions this season. Have a great evening, a good night, and a great spring and summer.